Good morning, students. So, today's topic is approach to childhood cancer. So, how many of you have seen any patient in ward with cancer, whether it is blood cancer, you or anybody else? Okay. Which type of cancer? Huh? ALL it was. Okay. And how many of you have attended that some winter symposium arranged by pathology department for cancer? That is, I think 4 days or 5 days program. Nobody attended? Okay. So, just to have idea of understanding, so what will you think when you see any child with cancer, especially ALL, in your vicinity or in your ward? What do you think, and how will you talk about the child's prognosis to the parents? Please tell me. Hmm. तो काउंसलिंग में क्या बोलेंगे? पेरेंट्स आर थिंकिंग दैट चाइल्ड इज गॉन. हाँ, तो इन जनरल कितना परसेंट चांस है कि क्योर हो जाएगा? इन जनरल, जस्ट टू हैव आइडिया ऑफ you people, I am asking. We will discuss quickly. तो भी दिमाग में कुछ तो होगा ना, भले ही पढ़ा हुआ हो नहीं पढ़ा हुआ हो, कहीं से भी आया. Nothing? Okay. Anybody else? कितना चांस है? बोलो. नो आइडिया. ओके, सो we'll discuss. So, childhood cancer actually is, as compared to adult cancer, it is a small group, only 1.2% of the all cancer in less than 15 year of age. But why we need to study it separately then? Cancer is cancer. Why we need? Because childhood cancer has better outcomes because of different biology, lesser comorbidities like diabetes, hypertension, so many things. Heart disease will be there in adults, but in children usually these diseases are not there. Can tolerate higher doses of chemotherapy because they have young cells and they will regenerate very fast than the adult people, and they have less comorbidities and more long term side effects because they live longer. अगर 60 साल के इंसान को आप कीमोथेरेपी दे रहे हो तो आप 20 साल बाद के साइड इफेक्ट की नहीं सोचोगे, बट बच्चों में सोचना पड़ेगा. ग्रोथ, डेवलपमेंट, स्कूल परफॉर्मेंस, फर्टिलिटी, ऑल दीज इश्यूज which may not be there in elderly people, but it is there in children. Risk stratification and optimal use of therapy, especially radiotherapy, is necessary in these patients to avoid the long term side effects. Then children has family issues which adult don't have. Kids specific environment is needed for proper compliance, and pediatric teams and pediatric protocols are needed to follow for children with cancer. So, what are the type of cancers in children usually seen? It is most common is leukemia, then among solid tumors it is brain tumor, then soft tissue sarcomas, neuroblastoma, epithelial cancers, non-Hodgkin's lymphoma, Wilms tumor, Hodgkin's disease, germ cell tumor, retinoblastoma, osteosarcoma, Ewing sarcoma, liver tumors like hepatoblastoma and LCH, histiocytosis X. So, these are common cancers seen in children, and some of these cancer actually not seen in adults. So, usually only for only in children it is, these are seen like hepatoblastoma, Wilms tumor, neuroblastoma and retinoblastoma. These are very rarely, some case report may be there in adults, otherwise these are not seen in adults. So, in children also, in different age group, different incidence of these cancers are there. For example, you can see here leukemia, CNS tumor, neuroblastoma, germ cell tumor are more common in infants, okay? And neuroblastoma incidence drastically decreases over age, and in adolescent it is almost nil, okay? And lymphoma in incidence increases with age, in adolescent it is more common, and leukemia actually every age group it is affected. Then soft tissue sarcomas more common in like rhabdomyosarcoma, muscle tumor, it is more common in adolescent. Wilms tumor highest age is 1 to 4 year, before that less common and after that also less common. Then bone tumors and thyroid cancers more common in adolescents. So, these are some specific examples, otherwise all tumors can be found in any age group. Approach to diagnosis, early diagnosis and treatment is the key, that is the most important thing. Still we do not realize the importance of time to diagnose and time to treat even at tertiary care centers. Not, I am not talking about like any for medical officer level or district hospital level, but we have to be primed, we have to be like standing on toes to act for diagnosing these cancers and for treatment, and many a times we need presumptive treatment. Usually we have to diagnose first, then stage and then plan, counsel and then treat. So, this is the sequence, but not sometime actually many a times we need presumptive treatment while waiting for the biopsy report, because biopsy report also may take long time. So, that idea we should have, that what we can do to save the child, because while waiting for the report only we have seen patients dying. 85% of the usual symptoms and sign, 85% will have what symptom sign they will have, like fever, some lymphadenopathy, hepatosplenomegaly and some swelling which may mimic like abscess or may mimic like some benign tumor, jaundice if liver tumor is there. So, depending on the site symptoms may be there, and all symptoms may be seen in many other diseases also. That is the reason that we can't blame any primary care doctor that they are not diagnosing on time, but because of these kind of usual symptoms the delays are there. So, we have to keep these DDs on at appropriate place, not at the last, like our teaching is there that malignancy should come last. These are rare, especially in children, but these are not so rare. If you go in ward, in our ward about 1/3 beds are occupied with malignancy patients only. So, 15% will have unusual symptoms, okay. So, which will clinch the diagnosis, okay, it is malignancy, like any tumor is there. So, tumor is tumor, it means it is most likely in children, any tumor is most likely malignant unless proved otherwise. Then chronological history, we should look at the chronological history, that first what happened first, then what, and the usual symptoms, fever, pallor, bleeding, abdominal distension, these are related to blood cancers. Mass and symptoms due to compression may come anywhere, wherever mass is there. If it is chest mass, then cough, breathing problem. If it is abdominal mass, then the mass may be palpable, maybe there is some obstruction, maybe obstruction of the biliary system causing jaundice or urinary obstruction if it is like bladder mass or prostatic rhabdomyosarcoma. So, all these symptoms are related to the pressure symptoms where the mass is present and causing compression. Examination, we should never miss in any malignancy patient, lymphadenopathy, hepatosplenomegaly, especially in left lateral position. We should try to palpate spleen when child is inspirating. That time actually you can be able to palpate even the mild enlargement of the spleen, and even mild enlargement of spleen in that position is important. Maybe benign causes, I am not talking that these are malignant only, but we should think of malignancy if splenomegaly is there. Then mass lesion, properly if we put the hand and put our fingers inside with pressure, then we will be able to find out whether any mass is there or not in early stage. Otherwise, obvious, if parents are coming with the mass, then it may be too late actually. Then testis should be examined in all males, all male children, because there may be some germ cell tumor there, there may be some rhabdomyosarcoma or lymphoma or leukemia itself. So, this is this one testicular enlargement pic I put, which was a real patient, and this was Wilms tumor. So, what is the correlation with the Wilms tumor and this unilateral testicular enlargement? Any theoretical knowledge you gained till now? This was actually part of hemihypertrophy because of our habit to see at genitalia, because any malignancy can recur only in genitalia also, even the leukemia. So, we picked up this, but actually this was later we found that it was a part of hemihypertrophy. So, that is why unilateral testicular enlargement leg length discrepancy also was there. So, mnemonic by American Cancer Society, children, continued unexplained weight loss. These are signs of cancer. Headaches with vomiting in the morning, increased swelling or persistent pain in bones and joints, lump or mass in abdomen, neck or anywhere, development of whitish appearance in the pupil of the eye or sudden changes of vision, leukocoria, recurrent fevers not caused by infections, excessive bruising or bleeding, often sudden, noticeable paleness or prolonged tiredness. Symptoms and signs of childhood cancer: generalized malaise, fever, adenopathy, which suggests diagnosis of lymphoma, leukemia, Ewing sarcoma or neuroblastoma, because these tumors affect bone marrow, and when bone marrow affection is there, then there may be cytopenia, infections, or without that also lot of cell proliferation and death will be there, which will cause fever and systemic symptoms. And then head and neck. In head and neck, headache, nausea and vomiting may be seen in brain tumor or leukemia affecting the CNS. Febrile seizure may be seen in the brain tumor. Earache, rhinitis, pharyngitis may be seen in soft tissue sarcoma in the head and neck area. Then epistaxis can be seen in leukemia or nasopharyngeal tumor. Then adenopathy seen in neuroblastoma, thyroid, soft tissue sarcoma, lymphoma, leukemia. There are many diseases, but if it is spread all over like cervical, axillary, inguinal, maybe abdominal or inside the thorax also, the multiple lymphadenopathies, then it is not like neuroblastoma or thyroid or soft tissue sarcoma. These will cause regional lymphadenopathy. So, lymphoma, leukemia is more likely. Then extrathoracic soft tissue mass in case of soft tissue sarcoma and bony mass in case of Ewing sarcoma or neuroblastoma. PNAT and Ewing sarcoma is same part actually. In bones usually we call it as a Ewing sarcoma, in soft tissue it is called either Ewing sarcoma, PNAT both. Intrathoracic adenopathy, then lymphoma and leukemia are likely, and in musculoskeletal soft tissue masses, then rhabdomyosarcoma, other soft tissue sarcoma, PNAT, these are likely diagnosis. Bone mass or bone pain, then bone tumor may be there, which is osteosarcoma, Ewing sarcoma, bone lymphomas, neuroblastoma affecting the bones and leukemia affecting the bones. External abdomen, soft tissues, external abdomen, if any soft tissue mass is there, then soft tissue sarcoma and PNAT, these are the common differentials. especially in chest. If it is there, then it is more commonly like PNAT arising from the ribs, which is called as Eskin tumor. Internal abdomen, symptoms may be diarrhea, vomiting, hepatomegaly and or splenomegaly, neuroblastoma, lymphoma, hepatic tumor, leukemia. These are the differentials. In genitourinary symptoms, hematuria may be there, and that may be because of Wim's tumor or soft tissue sarcoma, especially rhabdomyosarcoma in that region, and trouble voiding, vaginitis, peritesticular mass may be manifestation of soft tissue sarcoma, most commonly rhabdomyosarcoma. Then there are symptoms and signs in children suggestive of cancer that require immediate evaluation. So, if hypertension is there, then we should do X-ray and sonography. Renal or adrenal tumor or neuroblastoma are the differentials. If weight loss, which is sudden onset, then abdominal sonogram should be done. Any malignancy can cause weight loss, especially lymphomas. Then Pateki is there, then there is platelet low platelet count in the patient, and which may be manifestation of something affecting the bone marrow, which is leukemia or neuroblastoma. So, CBC should be done with peripheral smear properly. Then adenopathy unresponsive to antibiotics, then you look for surgical, go for surgical consultation, chest X-ray, CBC, differential, and leukemia and lymphoma are the possibility. Endocrine abnormalities like growth failure, and do hormonal assays. Sometimes pituitary tumors may cause growth failure, so you should investigate, and that can be diagnosed with actually tumor markers also, and then MRI. Then electrolyte disturbances, CT, hypothalamic area, and that for diagnosis of hypothalamic tumors. Sexual abnormalities, do abdominal CT for gonadal tumors, and Cushing syndrome, endocrine consultation for adrenal tumors. In case of brain symptoms, neurology or neurosurgery consultations with imaging for brain tumor need to be done, and signs may be any like morning headache, vomiting, and cranial palsy, ataxia, dilated pupil, papilloedema, afebrile seizures, hallucinations, aphasia, unilateral weakness, paralysis. So, these are common seen as sign symptoms, but if focality is there and there is chronicity, then we should think of this, and especially if early morning problem not related to infection, something we think that it is not related to acute infection, then we should think of imaging, and in imaging we can diagnose. It is very important for brain tumors to diagnose early, because bigger the brain tumor, then it is very difficult to remove, because normal brain tissue will be there around. Then in eyes, white spot, proptosis, blindness, wandering eye, intraorbital hemorrhage, if these are there, then ophthalmological consultation. Retinoblastoma can be quickly diagnosed by ophthalmologist only, and then metastatic rhabdomyosarcoma or neuroblastoma may manifest with orbital mass or periorbital ecchymosis type of presentation. Then ears, in ears, if bulging mass in external canal, mastoid tenderness, swelling, puffy face, neck, pharyngeal mass, periodontical mass, loose teeth, these are signs of some tumor inside the ENT region. So, CBC, differential and imaging studies are important. If it is leukemia and some leukemic deposits there, then CBC can diagnose, otherwise imaging studies will have some idea that whether there is some mass there or no. LCH, rhabdomyosarcoma, mediastinal tumors, then lymphomas, nasopharyngeal carcinoma, and osteosarcomas. So, these are the common tumors which ENT people see. And then thorax, in thorax, if thoracic mass causing coughing, fever, asthmatic kind of problems, allergies, then do CBC and chest X-ray and other imaging, CT scan if needed. Soft tissue sarcoma, mediastinal tumor and metastatic tumors are possibility. In abdomen, intra-abdominal mass, then do CBC. See, CBC comes everywhere because leukemia can have infiltrated anywhere in the body. So, if leukemia, then easily we can diagnose with just smear. It is not so easy also. Yes, I am saying that it is easily, but if you see the CBC reports, you won't find anything there unless it is profound cytopenia. Okay. You have to discuss with the pathologist to see the smear for blast, then only you can diagnose. Otherwise, frank leukemia with more than 1 lakh count, WBC count, having 90% blast also not usually diagnosed on CBC, which is done on the private. Fine. So, then abdominal tumors like Wilms tumor, soft tissue sarcoma, neuroblastoma, hepatoblastoma, hepatocellular carcinoma. The hepatocellular carcinoma is rare in pediatrics, but can be there. Then genitourinary, testicular or vaginal mass, musculization, feminization because of hormonal secretory tumors. Then you should go for urine analysis, then CBC, differential, sonogram of pelvis or abdomen, and germ cell tumor, rhabdomyosarcoma, adrenal tumor are differentials. Musculoskeletal same. Then we should look for some chromosomal disorders also underlying, because these will have some increased risk of malignancy. Like Down syndrome, commonly we see leukemia, testicular and retinoblastoma, but leukemia is common, especially AML is, oral ALL is more common, but AML is more times seen than the normal other children. Okay. Because overall ALL is common, that is why ALL is more commonly seen in Down syndrome, but the risk is more for AML. Then Turner syndrome, Klinefelter, then XY gonadal dysgenesis, trisomy 13, trisomy 18, XYY mosaic. So, these also may lead to some kind of cancers. Xeroderma pigmentosum, Bloom syndrome, Fanconi anemia, ataxia telangiectasia, these are having like chromosomal fragility issues, and these also may later on have increased risk of cancers. Neurofibromatosis type 1, MPNST and JMML we commonly see, glioma is also common, low grade glioma, opticochiasmatic glioma is common in neurofibromatosis. Then tuberous sclerosis, von Hippel-Lindau disease. So, these are genetic syndromes predisposing to childhood cancers. Immune deficiency disease also predisposes to childhood cancers like X-linked lymphoproliferative disease, Bruton's A gamma globulinemia, severe combined immunodeficiency, Wiskott-Eldridge syndrome, IgA deficiency, common variable immunodeficiency, DiGeorge syndrome, ataxia telangiectasia and Chediak-Higashi syndrome. So, we should also look for systemic signs of cancer. Here, what is the systemic sign which you can appreciate? Okay. So, this is like steroid toxicity, Cushing syndrome. Okay. So, why this Cushing syndrome is there? Because there is a tumor in adrenal. Okay. So, that is adrenocortical carcinoma, which is secreting the steroids which is causing it causes like precocious puberty, and if glucocorticoid secretion is there, then Cushingoid features. This both stages you can see, intraocular and extraocular. So, this is intraocular, it is bilateral retinoblastoma because genetic predisposition is there. So, RB gene is affected probably. So, here leukocoria you can see. Okay. So, if he comes in this stage, then we can try for eye salvage, vision salvage, if not possible at least we can salvage the life with removing the orbit and giving chemotherapy if needed. Okay. In this stage it is very difficult, it will be like orbital exenteration needed here, and with both eyes this child can't see now. So, it is better if we detect these kind of things early in the life. So, how we detect? We should educate the public also, doctors also, nurses also, all healthcare people, anybody who see eyes like this white eye reflex, which is more common in infants, okay, early age, and then probably we can see the eye with focal therapies without any chemotherapy need also. 5-year male, cough, cold, fever since 3 days, tonsillitis and lymphadenopathy, bilateral cervical 2 centimeter and axillary and inguinal 1 centimeter. CBC showed normal counts, but atypical cells blast 50% reported outside. Advised bone marrow, came for second opinion. Then child was asymptomatic, lymph nodes were same like mentioned previously, and no hepatosplenomegaly. What next? Will you do bone marrow or what to do? Otherwise asymptomatic. 50% blast means leukemia. You want to do bone marrow? कितने बोन मैरो करना चाहते हैं? हाथ खड़ा करो. कितने नहीं करना चाहते हैं? ऐसे तो मत करो कि किसी में भी हाथ खड़ा नहीं करो. कोई नहीं, थोड़ा एक थॉट प्रोसेस तो होगा ना आपका भी. कितने करना चाहते हैं? ल्यूकीमिया रूल आउट करना है. 8-10 हैं. ओके. कितने श्योर है कि नहीं करना चाहते हैं? चलो देखते हैं. तो एसिम्टोमेटिक है और बॉर्डरलाइन साइज ऑफ लिम्फ नोड है ना. तो ठीक है, सीबीसी कर लिया. LDH uric acid, because uric acid is elevated in many of the times in leukemia, okay, because of tumor lysis syndrome. So uric acid also done normal, PS showed no blast and CBC normal, but parents had doubt, outside doubt, ki can we rule out leukemia with just peripheral smear normal with no blast? So our answer will be no, we cannot. So then do bone marrow. So should we do bone marrow in this situation? Because parents want, and one outside report is there. करना चाहिए rule out करने के लिए, but that is an invasive procedure, needs sedation. Okay. So if child is not having symptom and no lymphadenopathy, no hepatosplenomegaly, CBC normal, no peripheral smear blast, LDH uric acid normal, why to do? Just for one report, which what they identified, sometimes atypical cells may be there because of some viral infections. They would have seen interpreted those as blast. So why to do bone marrow in that situation? Look at the size of the lymph node, that is actually just borderline. Okay. So we should just not act on the borderline, especially cervical lymph node. We can keep on follow up and then act later if needed. So reassured, kept on follow up. Resolution of lymph node size later in the course. So is lymphadenopathy significant? First we should see that more than 1 centimeter in general is the size. Supraclavicular any size, epitrochlear 0.5 centimeter and above, and in children more than 1 month, inguinal more than 1.5 centimeter is the size for significance. Otherwise in general it is 1 centimeter. So sub-centimetric if it is there, then not significant. So here it is 1 to 2 centimeters, so borderline, increase but borderline. But in cervical area you more commonly see lymph nodes transiently enlarged. So if child is otherwise asymptomatic, then we can actually wait. So if not significant, reassured, then if significant, then look at the whole picture, okay, fever, night sweat, weight loss, bleeding, liver, spleen, everything. If anything, any doubt, then investigate. If not doubt, then observe for 2-3 weeks, use antibiotic if needed, not always, if needed. And if not resolving, then investigate. Resolving, then observe and follow up for 6 to 12 months for if any again increase in size is there. Avoid treatment with steroid in any case, otherwise you will be in trouble, you won't be able to find out anything. So, other manifestation of childhood cancer is mediastinal mass. So, mediastinal mass, as you know, it is divided in anterior mediastinum, middle mediastinum and posterior mediastinum. So, mota you should just remember that anterior mediastinum common tumors are lymphoma and teratoma, and middle mediastinum lymph node hyperplasia and lymphoma, and posterior mediastinum neurogenic tumors. So, in general, okay, the common tumors only you should remember and take home this knowledge. Okay. Lymphoma, teratoma, lymph node hyperplasia, normal lymphadenopathy, regional, and lymphoma and neurogenic tumor in posterior mediastinum. Next case is 2-year-old girl, swelling over face, neck, upper chest since 1 month, breathing difficulty since 10 days, prominent veins on upper chest and neck, liver 4 centimeter, spleen just palpable in left lateral position, and generalized lymphadenopathy is there, and this is the X-ray and this is CT scan. So, here there is some mediastinal widening, and here this is the mass. Okay. This white is blood, this is intracardiac blood to heart, and anterior to heart there is a mass with some necrotic focus here. Okay. So, this is anterior mediastinal mass, and there is hepatomegaly and splenomegaly, and why swelling over the face and neck and upper chest in such situation? बताओगे फर्स्ट, कैसे एक्सप्लेन करोगे स्वेलिंग और फेस नेक अपर चेस्ट? ओके, swelling means edematous swelling, edema, not liver. और कुछ एक्सप्लेनेशन है? हार्ट फेलियर नहीं है, हार्ट फेलियर के कारण डिपेंडेंट एडिमा होगा, यहाँ से ऊपर क्यों है? एक और चीज बता दूं, डायलेटेड वेन्स आल्सो सीन, वीनस कंजेशन, मतलब यहाँ पे जो सुपीरियर वीना केवा सिंड्रोम वी कैन से in other words. So, SVC is like compressed, so the blood is retained above that, whatever coming from head and neck, na? And that blood pressure will actually lead to more capillary leakage, and that is how edema. So, there may be edema, swelling, increase perfusion or increase redness over the face, and some dilated veins also may be there. So, this is, it means there is compression because of the mass there. So, it is a medical emergency. So, ऐसे केस में क्या करोगे आप? How will you diagnose? तुक्का लगाओ, फटाफट लगाओ, चलो आगे मैं बताऊंगा नहीं तो है। इमेजिंग कर चुके ना, अब हमें डायग्नोसिस चाहिए कि ये क्या है, ये एंटीरियर मेडिएस्टिनम है, लिम्फोमा हो सकता है, टेरेटोमा हो सकता है ना, और भी कुछ बिनाइन ट्यूमर भी हो सकता है, बट अनलाइकली इस एज में। बायोप्सी, तो इसका बायोप्सी लेना इजी है क्या? यहाँ पे निडल डाल के, तो क्या करेंगे, है ना, वही सोचना है, सीक्वेंस वही मैं बताने वाला हूँ, तो थोड़ा ध्यान से सुनिएगा, है ना। सबसे पहले हम देखेंगे सीबीसी एंड पीएस, मे बी इट इज़ ल्यूकीमिया जस्ट, एंड पार्ट ऑफ ल्यूकीमिया की लिम्फेडेनोपैथी होगा, और हिपेटोस्प्लेनोमेगाली तो है ही है, उसको लिम्फेडेनोपैथी है ये बार भी, तो एक और लिम्फेडेनोपैथी मिडिएस्टिनम में भी है, दैट्स ऑल। सो ल्यूकीमिया हो सकता है, बट इन दिस केस सीबीसी एंड पीएस इज नॉर्मल, स्टिल ल्यूकीमिया कैन बी देयर, मे बी इन बोन मेरो, बट सीबीसी पीएस में सिंपली डायग्नोज तो नहीं हो रहा। देन एलडीएच इज 1274 बढ़ा हुआ है, इट मीन्स इंक्रीज सेल टर्नओवर इज देयर। यूरिक एसिड 5.8 नॉट सो हाई, ट्यूमर लाइसिस सिंड्रोम में नहीं लग रहा। फिर अब क्या ऑप्शन है डायग्नोसिस के, क्या ल्यूकीमिया के लिए बोन मेरो करें, या जो पेरिफेरल लिम्फ नोड है उनका बायोप्सी करें, या मीडिएशनल मास से बायोप्सी करें, ये ऑप्शंस है। क्या करना चाहेंगे? पहले तुक्का लगाते रहो, अपन आगे बढ़ते रहते हैं, थोड़ा इंटरेक्टिव रहेगा। हैं? कौन सा बायोप्सी? लिम्फ नोड, वेरी गुड। एक्चुअली इन दिस ऑर्डर ओनली वी शुड सी द पॉसिबिलिटीज, बोन मेरो, लिम्फ नोड एंड मीडिएशनल मास बायोप्सी। ओके, मोर डिफिकल्ट लास्ट। यहाँ का लिम्फ नोड इजीली निकाल सकते हो, सर्वाइकल लिम्फ नोड इजीली निकाल सकते हो, तो वो पहले सोचना चाहिए। तो लेकिन अब बोन मेरो तो ठीक है, इन्वॉल्व हुआ तो काम का है, इन्वॉल्व नहीं हुआ ये भी हो सकता है ना, मे बी इट इज जस्ट लिम्फोमा not involving the bone marrow, or even if involving, it is some other kind of lymphoma which cannot be diagnosed immediately, like lymphoblastic lymphoma or leukemia can be diagnosed if from bone marrow immediately with flow cytometry, but बाकी वो solid जो सैंपल होगा उससे हम डायग्नोसिस इमीडिएटली नहीं निकाल पाएंगे, थोड़ा टाइम लगता है ना, बायोप्सी को प्रोसेस होने में टाइम लगता है। तो यूजुअली 3 to 5 days इट टेक्स फॉर मॉर्फोलॉजी रिपोर्ट। अगर आप ज़्यादा ही फ़ोन करके अच्छे से पीछे पढ़ो, खूब टाइम लगाओ उसमें, तो 3 दिन में रिपोर्ट आ जाएगा, ठीक है। उसके बाद इम्यूनोहिस्टोकेमिस्ट्री करना होगा, उसके बिना डायग्नोसिस पूरा पॉसिबल नहीं होगा, तो उसमें और लगेगा 3 से 5 दिन, तो लगभग 7-10 दिन लग जाते हैं, ठीक है ना। 7-10 दिन तक ये पेशेंट रहेगा क्या? मेडिकल इमरजेंसी है, और बिना डायग्नोसिस के स्टीरॉयड या कुछ भी देना प्रॉब्लम है, तो क्या करना है, ठीक है ना। तो हमको कोई लिक्विड सैंपल चाहिए, कोई लिक्विड सैंपल और पॉसिबल है इसमें? बोन मेरो तो है, देख लेंगे, बोन मेरो करना है, और कुछ पॉसिबल है? कुछ दिख रहा है? ये क्या है? प्लूरल इफ्यूजन है ना। तो प्लूरल इफ्यूजन है, तो सबसे पहले हमको लिक्विड ट्राई करना चाहिए, क्योंकि लिक्विड में फ्लो साइटोमेट्री करेंगे, 1 घंटे का काम है, डायग्नोस पूरा हो जाएगा, सारे मार्कर, चाहे आप कितने ही मार्कर लगाओ उसमें, सब एक साथ हो जाएंगे, ठीक है ना। अगर हम करना चाहें तो 1 घंटे में डायग्नोसिस दे सकते हैं, बाकी सब में टाइम लगने वाला है। तो ठीक है, प्लूरल फ्लूइड लिया, प्लूरल फ्लूइड में ब्लास्ट पॉपुलेशन आई 60%, और CD7, 8, 4 ये सब पॉजिटिव है, बाकी सब नेगेटिव है। तो ये क्या है? क्या है ये मार्कर? व्हाट डज इट इंडिकेट? सो दिस सिंगल डिजिट मार्कर्स आर फॉर T सेल, ओके, एंड दिस 20, 19 ये B सेल के लिए हैं, 13, 33 CD117 ये माइलॉइड के लिए हैं, और HLA-DR एंड CD34 दीज आर फॉर immature cells, okay. So this is the pleural fluid immunophenotyping. So immunophenotyping is immunophenotyping. Phenotyping means surface markers. Some on cell there are some markers which identify the lineage of that cell, और हम इम्यूनोलॉजिकल टेक्निक से उनको डिटेक्ट कर रहे हैं, और फिर फ्लो साइटोमेट्री मशीन में उसको फ्लो करके एक एक सेल को एक एक अपर्चर से निकाल के उसको काउंट कर रही है मशीन। तो लाखों सेल काउंट कर सकती है फ्यू सेकंड्स में, है ना, मशीन से। तो वो इसलिए वो फ्लो साइटोमेट्री प्रोसीजर है ना। बट इम्यूनोफिनोटाइपिंग कैन बी 2 types, in liquid sample or in solid sample. In liquid sample it is by flow cytometry, in solid sample it is immunohistochemistry, IHC. Histo means histology sample, ठीक है। सो दोनों ये डिफरेंस है। IPT इम्यूनोफिनोटाइपिंग इज अ कॉमन टर्म फॉर बोथ थिंग्स। So same day diagnosis, T cell lymphoblastic lymphoma, started on steroid and child was out of ICU on day 4. If you would have done mediastinal mass biopsy, you would have been waited for report, and if no communication, there is gap between the morphological report and the ISC also, because ISC need to be paid separately. Unless payment come, pathology will not start doing ISC by themselves. So that is the problem. Even you may have months will pass till you get the final report. So try liquid first. तो अगर ये फैसिलिटीज़ नहीं है तो क्या करना है, इमीडिएटली रेफ़र करना है, बल्कि बात करके रेफ़र करना है और बोल के कि भाई ऐसा ऐसा है, जो आप कर सकते हो वहाँ पे, जैसे ट्यूमरलाइसिस में है वो आपको वहीं स्टार्ट करना है, और कुछ एनीमिया है तो वो करना है, बट बाकी आपको रेफ़र करना है। तो लर्निंग पॉइंट्स, एनी फ्लूइड आईपीटी क्विक एंड कंफर्मेटरी डायग्नोसिस प्रिफरेबल बिफोर एनी बायोप्सी। बोन ट्यूमर, इसमें कुछ लर्निंग पॉइंट्स है, जैसे ओस्टियोसार्कोमा, इविंग सार्कोमा, these two are the common bone tumors in pediatrics. So in second decade osteosarcoma is common, and even sarcoma can be seen in first decade also, and second decade in adolescent. All bone tumors are most common in adolescent. Then site osteosarcoma will be commonly seen at metaphyseal region, and Ewing sarcoma at diaphysis, flat bone or soft tissues. And in osteosarcoma you can see osteoid and sunburst appearance. Here you can see this yellow arrow, there is some osteoid here, okay, and here you can see this triangle is forming because of periosteal reaction. This is Codman triangle, okay, and some sunburst appearance you can see here. Sunburst means the calcified rays like it is going on, irregular. It is not typical in this. Then onion peel in Ewing sarcoma, here you can see like periosteal reaction in onion peel way. So there is one line, then other line, then other line, like onion layers, okay. Then systemic symptoms are common with Ewing sarcoma because of bone marrow involvement. एब्डोमिनल मास, तो उसमें जो कॉमनली कंफ्यूजन होता है वो किडनी ट्यूमर एंड एड्रिनल ट्यूमर, ओके, और जब बड़ा हो जाएगा तो सब एक जैसा लगेगा कि किडनी इन्वॉल्व है कि किडनी से अराइज हो रहा है कि एड्रिनल से, पता ही नहीं लगेगा, ठीक है। तो कैसे हम डिफ्रेंशिएट करें न्यूरोब्लास्टोमा और विल्म्स ट्यूमर में? तो एक तो ये है कि इसमें कैल्सिफिकेशन होता है 90% में, और इसमें 10 to 15% में ही होता है, तो कम होता है। Then the behavior of neuroblastoma is to encase whatever come around. Like जैसे ये कोई वेसल है, ये न्यूरोब्लास्टोमा आ रहा है, तो विल्म्स ट्यूमर तो इसको पुश करता जाएगा, और न्यूरोब्लास्टोमा क्या करेगा, इसको वहीं रखेगा और साइड में से ग्रोथ करके इसको एनकेस कर लेगा। तो बाद में जब बड़ा ट्यूमर होगा तो वो बीच में आ जाएगा, है ना। तो इस तरह का अगर बिहेवियर है तो न्यूरोब्लास्टोमा फेयर में जाता है। ये सबसे इम्पोर्टेंट डिफरेंशियल मतलब पॉइंट है ये, जो कि डिफ्रेंशिएट करता है कि ये न्यूरोब्लास्टोमा लग रहा है कि कुछ और। फिर यंगर एज ग्रुप में कॉमन है न्यूरोब्लास्टोमा। न्यूरोब्लास्टोमा इज पुअरली मार्जिनेटेड एंड विल्म्स ट्यूमर इज वेल एनकैप्सुलेटेड। ये दिख रहा है यहाँ पे, वेल एनकैप्सुलेटेड, और इसका मार्जिन क्लियर नहीं है, मतलब यूँ बड़ा। देन एक्सटेंशन इनटू द चेस्ट इज पॉसिबल। अगर वो सिंपैथेटिक ट्रंक से अराइज हो रहा है तो वो तो ट्रंक तो चेस्ट में भी है और एब्डोमेन में भी है, तो हो सकता है कि वो सेम ट्यूमर एक्सटेंड कर रहा हो पीछे, तो वो पॉसिबिलिटी इसमें विल्म्स ट्यूमर में नहीं है। फिर एलिवेट्स द एओर्टा अवे फ्रॉम द वर्टिब्रल कॉलम, क्रॉसेस द मिड लाइन, एंड बोन और बोन मेरो मेट्स में बी देयर विद न्यूरोब्लास्टोमा, बट विल्म्स ट्यूमर डोंट गो टू बोन मेरो एंड बोन। तो हम बोन स्कैन भी नहीं करते विल्म्स ट्यूमर की स्टेजिंग के लिए। और एक सबसे इंपॉर्टेंट साइन है, ये क्या बोलते हैं इसको, ऐसे किडनी ऐसे दिख रही है, ये वाले किडनी टिश्यू, ये ट्यूमर है, इसमें नहीं दिख रहा है ऐसे, क्या बोलते हैं इसको, क्लॉ साइन, है ना, क्लॉक की जैसे जैसे उसने किडनी ने होल्ड कर रखा है ट्यूमर को। सो दैट मीन्स इट इज अ किडनी ट्यूमर, इट इज नॉट स्पेसिफिक टू विल्म्स, बट इट इज अ किडनी ट्यूमर अराइजिंग फ्रॉम द किडनी। देन डायग्नोस्टिक इन्वेस्टिगेशंस। ल्यूकीमिया के लिए कैसे इन्वेस्टिगेट करते हैं, ब्लड देखो, बोन मेरो देखो, फिर फ्लो साइटोमेट्री करो। सॉलिड ट्यूमर के लिए बायोप्सी करना पड़ेगा। ट्यूमर मार्कर से भी कर सकते हैं कुछ कुछ को, जैसे कि एपी इज इलेवेटेड इन हेपेटोब्लास्टोमा एंड जर्म सेल ट्यूमर, योक सेक ट्यूमर, जर्म सेल ट्यूमर का एक टाइप। देन बीटा एससीजी इज इलेवेटेड इन कोरियोकार्सिनोमा विच इज द टाइप ऑफ अगेन जर्म सेल ट्यूमर। देन यूरिनरी कैटेकोलोमिन्स आर इंक्रीज्ड इन न्यूरोब्लास्टोमा and pheochromocytoma. Pheochromocytoma is benign, neuroblastoma is malignant. Then specific scans needed, MIBG in case of neuroblastoma. तो न्यूरोब्लास्टोमा का डायग्नोसिस हम बिना बायोप्सी के भी कर सकते हैं, यूरिन कैटेकोलेमिन से और अमीबिजी स्कैन से। अगर ये पॉजिटिव है तो न्यूरो एंडोक्राइन ट्यूमर है। देन लास्ट केस आई थिंक, द 12-year-old मेल लेफ्ट मैंडिबुलर स्वेलिंग सिंस 2 months। दिख रहा है स्वेलिंग, यहाँ से भी दिख रहा है अंदर वाइट। फिर बायोप्सी लिया, और कोई जगह ही नहीं थी, बायोप्सी लेना ही था, सॉलिड ट्यूमर बायोप्सी से ही डायग्नोस होगा। तो बायोप्सी लेने के बाद में 5 days पोस्ट बायोप्सी दिस वाज द सिचुएशन। अब कैसे बायोप्सी का वेट करेंगे और कैसे उसको देखेंगे ऐसे ही कि नहीं तो बायोप्सी आएगी तभी काम करेंगे, नहीं पॉसिबल है ना, यू हैव टू डू समथिंग। तो हमने फिर तब तक हमको एक्चुअली मॉर्फोलॉजिकली थोड़ा आइडिया हो गया है ना, व्हेन वी डिस्कस विद पैथोलॉजिस्ट कि लुक्स लाइक इविंग सार्कोमा, एंड वो फिट भी हो रहा है कि सॉफ्ट टिश्यू सार्कोमा होगा, यहाँ इविंग्स हो सकते हैं। तो वैसे कोई भी सार्कोमा में कुछ ड्रग्स कॉमन होता है, तो वी कैन एक्चुअली स्टार्ट द ट्रीटमेंट फॉर इविंग सार्कोमा एंड देन मॉडिफाई लेटर ऑन। ओके, सो हमने वही स्टार्ट किया। तो आफ्टर 2 cycles ऑफ PNAT कीमो दिस वाज द सिचुएशन, इट वाज लाइक ड्राइड एंड लेटर ऑन इट एक्चुअली ऑटोमेटिकली वेंट अवे आउटसाइड। सो कैंसर इज डायग्नोस्टिक इमरजेंसी। कैंसर में ऐसे नहीं होता कि पहले 2 महीना लग गया पहले तो कि अरे 2 महीना पहले भी तो लगा है अब और लग जाएगा तो क्या होगा, ऐसे नहीं है। जब हमारे पास आता है सिम्टोमेटिक होकर के आ रहा है ना, तो इट मीन्स इट इज नाउ दैट पेशेंट इज वेरी लेस टाइम, नॉट ओनली फॉर द लाइफ, फॉर एक्सटेंट ऑफ सर्जरी, फॉर ओवरऑल साल्वेजनेस। इफ अगर हम उसको अर्ली डायग्नोस करेंगे तो ज़्यादा चांस है कि हम उसको क्योर कर पाएंगे। तो each one day is important and sometimes even hours are important. So we should not like think malignancy and do things slowly like any other patient. एक और डायग्नोस्टिक इमरजेंसी है, ये वीकेंड में आया, बायलेटरल ऑर्बिटल मास। ओके, बट MRI किया जल्दी से, तो MRI में ऑर्बिट इज लाइक रेटिनोब्लास्टोमा भी हो सकता है इस तरह से बाहर आ गया हो, बट और भी दैट वन आई ग्लोब इज नॉट इनवर्ड, इट इज ऑल अराउंड दैट। सो इट मीन्स आई ग्लोब कैन बी साल्वेज्ड, सो विजन कैन बी साल्वेज्ड, वी शुड एक्ट फास्ट, है ना। तो हमको क्या चाहिए, तो इसमें पॉसिबिलिटीज़ पहले सोचना पड़ेगा क्या क्या हो सकता है। तो पॉसिबिलिटीज़ क्या हो सकता है, एनी आइडिया? एक तो रेटिनोब्लास्टोमा बायलेटरल, और बट रेटिनोब्लास्टोमा में यूजुअली दोनों एक जैसा नहीं होता, पहले एक में बढ़ेगा बाहर आएगा फिर दूसरे में आएगा, दोनों एक यूजुअली एक साथ नहीं चलते, यहाँ पे एकदम सिमेट्रिकल है। तो समथिंग गोइंग सिस्टेमिक इलनेस, क्या न्यूरोब्लास्टोमा हो सकता है, पॉसिबिलिटी है ना। और रेब्डोमायोसार्कोमा यूजुअली यूनिलेटरल, ऐसा बायलेटरल नहीं होगा, रेयरली हो जाए तो हो जाए, बट यूनिलेटरल होगा क्योंकि द प्राइमरी विल बी इन ऑर्बिट ओनली, और ऑर्बिटल रेब्डोमायोसार्कोमा। सो हियर इट इज नॉट लाइक प्राइमरी एट वन पॉइंट वन साइड। सो और क्या हो सकता है, सिस्टमिक इन्वॉल्वमेंट वाला LCH हो सकता है, फिर AML माइलॉइड सार्कोमा, या इवन AML में भी बायलेटरल, इवन ल्यूकीमिया में भी, ALL में भी हो सकता है। सो ये सारा पॉसिबिलिटी सोचा, ठीक है। तो हम क्या दे सकते हैं उसमें, अगर डायग्नोसिस है तो पर्टिकुलर ड्रग दे सकते हैं, नहीं तो हम स्टीरॉयड तो कम से कम स्टार्ट कर सकते हैं, थोड़ा एडिमा भी कम होगा, अगर वो ल्यूकीमिया है तो रिस्पॉन्ड भी कर सकते हैं। तो हमको इसमें AML का चांस सबसे ज़्यादा लगा, तो हमने वी आस्क्ड ऑप्थेल्मोलॉजिस्ट टू जस्ट डू बायोप्सी एंड वी डिड बोन मेरो, कि उसमें अगर माइलॉइड ल्यूकीमिया मिल गया तो अच्छी बात है। तो बोन मेरो प्रोसेस्ड ऑन मंडे, so which showed that it showed 8% of the atypical cells myeloid like, तो पॉसिबिलिटी तो है, बट हम ट्रीटमेंट जस्ट आफ्टर बायोप्सी वी जस्ट स्टार्टेड ट्रीटमेंट विद लो डोज साइटारेबिन थिंकिंग ऑफ माइलॉइड सार्कोमा। सो दिस वाज आफ्टर 1 week or 10 days I think of AML chemotherapy. So quick response and child can see, okay. And this is the mark for the biopsy, from here biopsy was done. So childhood cancer is sometimes medical emergency to treat after adequate sampling. After adequate sampling, डू नॉट ट्राई एनी ट्रीटमेंट बिफोर सैम्पलिंग, चाहे जो हो, अगर मर रहा हो तो मर ही जाए, क्योंकि बाद में भी नहीं बचेगा वो, अगर आपने डायग्नोज नहीं किया तो। जाना कहाँ है, किधर जाना है, क्या ट्रीटमेंट करोगे, कुछ पता नहीं। या तो आपका प्लान है कि मेरे को इसको क्लिनिकली टी सेल लिम्फोब्लास्टिक लिम्फोमा मैनेज करना है, कोई मेडिसिनल मास है, उसका आप बिना डायग्नोसिस कर दिए तो कभी ऐसा पॉसिबल हो सकता है, बट यू कैन नॉट डू, एक्चुअली एथिकल इश्यूज ऑल्सो मे कम हियर, because there is possibility of biopsy. If you cannot do, somebody else will do, so just send. Then staging investigations. स्टेजिंग इन्वेस्टिगेशन का एक कॉमन जो प्रिंसिपल है वो बता रहा हूँ। लिम्फोमा होल बॉडी पेट सीटी वो करना है ना। सॉलिड ट्यूमर्स में यूजुअली बोन मेट्स के लिए बोन स्कैन करते हैं और लंग्स के लिए सीटी थोरेक्स करते हैं। एमआरआई इज नॉट अ गुड टेक्निक फॉर लंग्स, ओके, सीटी स्कैन इज बेस्ट टेक्निक। देन बायलैटरल बोन मैरो एस्पिरेशन एंड बायोप्सी इन सेलेक्टेड ट्यूमर्स जैसे कि न्यूरोब्लास्टोमा, रेब्डोमायोसार्कोमा, पीएनईटी, ओके। तो बायलैटरल क्यों करते हैं? और कभी कभी हम जो सीएनएस में स्प्रेड हो चुका है रेटिनोब्लास्टोमा उसके लिए भी बोन मैरो करते हैं। सो दीज ट्यूमर्स विल इनफिल्ट्रेट द बोन मैरो एंड पैची इनफिल्ट्रेशन विल बी देयर, सो इन यूनिलैटरल यू मे नॉट बी एबल टू फाइंड आउट, सो दैट्स व्हाई इट इज डन बायलैटरल। एंड बायोप्सी करना है, सिर्फ एस्पिरेशन से काम नहीं चलेगा, हो सकता है एस्पिरेशन में ओनली ब्लड आ जाए, सो एस्पिरेशन एज वेल एज बायोप्सी दोनों करना है। Then treatment plan, leukemia lymphoma usually chemotherapy only, there is no role of surgery and no role of radiotherapy in at large, but there is role limited, but in general no role. Then for solid tumors, individualized combination of chemotherapy, surgery and radiotherapy will be done, but the sequential administration of this treatment is without any gap is important. अगर अभी कीमो लिया, कीमो में बिल्कुल छोटा हो गया और फिर सर्जरी नहीं कराया टाइम पे और तो वो वापस बढ़ जाएगा, तो वो कीमो भी फिर वापस काम नहीं करेगा। सो दैट टाइम इज वेरी इंपॉर्टेंट टू फॉलो दैट टाइम लाइन, ओके, अनलेस एनी मेडिकल इंडिकेशन इज, सोशल रीजन से उसको विदहोल्ड नहीं करना चाहिए, बट फिर भी करते हैं लोग, उसका इलाज नहीं है, ठीक है। तो जिसको जो चाहिए उनके रिस्क ग्रुप के हिसाब से, सबका ट्रीटमेंट सेम नहीं होता है। जैसे रेब्डोमायोसार्कोमा को कीमो देंगे, फिर सर्जरी करेंगे, फिर आरटी देंगे, फिर कीमो देंगे, सब में ऐसा नहीं होता है। अगर वो लो रिस्क में आ रहा है या इंटरमीडिएट रिस्क में आ रहा है, पूरा रिमूव किया है मार्जिन के साथ में, तो आरटी का जरूरत नहीं है। इन पीडियाट्रिक्स वी ट्राई टू अवॉइड आरटी बिकॉज ऑफ लॉन्ग टर्म साइड इफेक्ट्स ऑफ आरटी। तो पीडियाट्रिक में एक और लाइन का इश्यू आता है, इतना हम कीमो देंगे, कहाँ देंगे, तो we can actually put central lines. So this is chemo port. The chemo port is put under the skin, and then this is Hubbard needle, L shape. This needle is put in this, so it is connected the whole system. When you don't need, just remove it. And this is the PICC line. Here it is little inflamed. This course of the PICC line. It is put in the cuboidal fossa. PICC line means peripherally inserted central catheter. So now outcome which I asked in beginning. So you can see in 1940, except Hodgkin's lymphoma, which that time it was treated with RT alone, radiotherapy alone, and many patients, 40% of the cases were cured that time also with just RT, but all other are having less than 20% survival. And in 2000 you can see how the survival is increased for everything, okay, except not much for the AML. AML is still a bad cancer to see in pediatrics also. So after 2000, now it is 2025. So you can realize that how far these graphs would have gone. So if you see any child around or in ward, always give some positive hope that these cancers can be cured. It is, and do not try to give any negative thing in them. There are some cancers which cannot be cured, that depend on the risk stratification and previous treatment taken and relapse status, all that. So evolution of curative treatment. What is the time? आपने मेगलोब्लास्टिक एनीमिया सुना होगा, उसमें भी ब्लास्ट होता है, मेगलोब्लास्ट, और कैंसर में एएलएल में भी ब्लास्ट होता है, तो एनीमिया होता है कैंसर में भी। तो किसी ने सोचा कि हाउ कैन वी ट्रीट दोज ब्लास्ट, शुड वी ट्रीट विथ फॉलिक एसिड लाइक वी ट्रीट मेगलोब्लास्टिक एनीमिया. तो फॉलिक एसिड से उनको ट्रीट करने की कोशिश की तो वो ज़्यादा हो गया. तो इट मीन्स दे नीड सम एंटीफोलेट. सो दैट्स हाउ एंटीफोलेट वाज यूज्ड फर्स्ट टाइम फॉर childhood cancer. So methotrexate is antifolate used, and after that there was multiple agents protocol was made to treat childhood cancer, and there was 50% cure rates seen, and 50% of survivor had CNS relapse. So that's why then craniospinal radiotherapy was introduced, and after that cranial RT and intrathecal chemotherapy is used, and now we don't use cranial RT at all, we use only intrathecal and high dose methotrexate. So this is how evolution of the CNS directed therapy in ALL. So multidisciplinary treatment is needed with pediatric oncologist, pediatric surgical oncologist, pediatric radiotherapist, pathologist, radiologist and nuclear medicine, and other pediatric subspecialties like cardiology, endocrinology as per issues. And there should be some tumor board where we all sit together and discuss the difficult cases. But despite all improvement, the outcome of leukemia, lymphoma and other childhood cancer is inferior in India as compared to Australia, China and Thailand. Hai. So why inferior outcome? Because of unfavorable histology in India, lack of awareness of symptoms and signs among doctors, partial treatment without confirmation, alternative medicines and steroids, still it is very common. Lack of teamwork, it is very common, lack of teamwork also. Lack of systematic good quality clinical trials, which is now actually in India we are having some trials, and limited financial resources which is no longer there, especially in AIIMS Bhopal. We don't refuse any child with cancer just because of finances. Difficulty in accessing health care, false stigma of incurability, and refusal and abandonment of treatment is very common still even at AIIMS Bhopal. More infections in India than other countries because of unhygienic situations. So these are the reasons of inferior outcomes, and to overcome that we need lot of support. Pediatric oncology nursing team which is able to give chemotherapy, central line care, counseling, pharmacist, nutritionist, occupational therapist, psycho-oncologist which we have, play therapist we have, and financial and social worker we have, data manager we have, research officer. So all these support team is needed, partially we have all this here, and also we should take care of the normal sibling because they will suffer when child is here for treatment. Extramural support is possible with lot of funds. Among these we have CanKid support which provides home away from home and food and stay services here in front of AIIMS Bhopal, and also financial help also. Okay, so I think we will stop here. In general, leukemia it is very difficult to cover, but most of part, diagnostic part and flow cytometry already we have covered. But what common leukemia are there in the children are ALL and AML, CML and JMML, these four. The CLL is not in pediatrics, not seen in pediatric age group. So classification pre-B, actually all these is obsolete now. Only L3 type here, L1, L2 and L3, these are in your books may be written, in pathology books especially. So L3 type you can see here, these are vacuoles, okay, cytoplasmic vacuoles. If these are there, then it is L3 and maybe Burkitt's phenotype. This is Burkitt's phenotype. So this is treated differently than other leukemia. So this is the difference, and still, so this classification is still used for L3 purpose. L1 and L2 there is no management difference. So there are prognostic factors There are some favorable factors and some unfavorable factors. We will just see the unfavorable factors which you were asking that time. Age 1 less than 1 and more than 10 is unfavorable. WBC count at presentation more than 50,000 is unfavorable. T cell unfavorable. Hypodiploidy, translocation 411, translocation 922, these are unfavorable. And clinical response, if it is poor prednisolone response with just 7 days of prednisolone. But if you have before referring you have given prednisolone, then we won't be able to actually calculate proper 7 days of prednisolone. So, we will lose this criteria. And induction failure, which is more than 25% blast after induction chemotherapy for 1 month, and MRD positive at end of induction, minimal residual disease, which is done by flow cytometry. So, these are the unfavorable criteria. In AML, special features are like gum hypertrophy, myeloid sarcoma, which may have tumor like in orbit we saw the last case, skin, paraspinal, DIC which is common in with M3 phenotype, and granules and or rods on the smear. So, these are some special things with AML as compared to ALL. So, therapy differences in ALL we give induction consolidation which goes on for 6 months to 7 months. After that 2 years of maintenance chemotherapy with 6 MP and methotrexate. In AML there is no maintenance therapy, only high dose therapy will be there for 4 cycles, which includes cytarabine and daunorubicin for 2 cycles and high dose cytarabine for next 2 cycles. So, only 4 cycles, 4 month therapy and over. One difference is like there L3 is different from all others, here M3 is different from all others. M3 is APML, acute promyelocytic leukemia. So, AML M3 is treated differently even without chemotherapy. There are targeted agent, translocation 15-17 is seen, and the drugs are cis retinoic all trans retinoic acid and that one arsenic trioxide. So, these two are used for treatment of APML, very good response, about 95 to 100% chance of cure. But most common cause of death in these is bleeding in initial 15 days of therapy. So, there are different genetic abnormalities seen with AML, but the good prognosis factors are 821, inversion 16 and 15-17, which is APML. And Down syndrome, WBC less than 1 lakh, and these 3 cytogenetic features are favorable in AML. Thank you.